Hello, I'm Dr. Haig Satrakian, bringing you a little POCUS review just in time for your next pediatric patient. Today we'll be reviewing a case from the community to highlight some of the unique challenges posed by the Pediatric FAST exam. An ambulance crew calls ahead to your facility to give report on an infant they're transporting from the scene of a motor vehicle accident. The patient appears stable, but was noted to have a faint mark over their lower chest and upper abdomen under the car seat restraint. They also vomited. Pediatric trauma is rare at your facility, but your team prepares a resuscitation bay. You walk along the stretcher while the ambulance crew brings the patient to their room, and are reassured by their overall stable appearance. The patient has a heart rate of 145, blood pressure of 82/46, oxygen saturation of 98%, and a respiratory rate of 22. As part of your initial evaluation, you perform a FAST exam, and in every view, you see what appears as free fluid, implying injury worse than you had suspected based on the patient's appearance. In the right upper quadrant view, there is a dark stripe between the liver and diaphragm. Is this free fluid? There is no fluid in Morrison's pouch or around the liver tip. If it's not fluid, what is it? In the subxiphoid and peristernal views, you see a thin dark stripe around the heart, which mostly disappears during diastole. Is this an effusion or blood? Just beside the bladder is a small but clearly visible pocket of free fluid. It's not much, but could it be pathologic? Based on these findings, you're starting to worry about organ injury due to blunt trauma, and you start to work down your blunt abdominal trauma algorithm. This patient is hemodynamically stable and has a positive FAST exam, so you plan to obtain a CT of the patient's abdomen. That being said, you wonder if you're interpreting your ultrasound images correctly, and you regret having to subject this very stable appearing patient to a high radiation dose. You draw labs and call for chest and pelvis films. The x-rays are normal. The parents arrive, happy to see their baby, who reaches for them eagerly. They ask if you found any injuries and you share with them about the ultrasound findings, but your sense that their baby is going to be okay. The closest pediatric trauma center is 3 hours away, and you call them for advice. They recommend proceeding with CT to clarify the extent of the injuries. A few hours later, your CT shows trace pelvic fluid without organ injury. After another conversation with the patient's family and another reassuring physical exam, you admit them to your hospital's general pediatric ward for observation. They're discharged in the morning after an uneventful night. The next day, you sit down to review the literature on this subject. Your search starts with these two simple questions. Can FAST be used in pediatrics? Is FAST interpreted the same in children as it is in adults? In your quick search, you're reminded of large prospective studies showing the high sensitivity and specificity of the FAST exam in adult trauma patients. While you see a wide range of findings for the pediatric FAST exam depending on the study size and population, the trend you notice is one of low sensitivities with generally better specificities. The specificity seems to vary depending on how positive findings are defined. Why is this? In a large meta-analysis, Holmes et al. Noted that up to 34% of pediatric patients with confirmed intra-abdominal injuries had no hemoperitoneum. This may contribute to the poor sensitivity of the exam in children. Investigators have looked at how to compensate for this challenge. In a large prospective observational study of more than 2,000 pediatric blunt abdominal trauma patients, Bennett et al. Showed that the FAST exam had higher sensitivity in patients that were more injured, those who required interventions such as transfusion or laparotomy. Others have focused on how to make the FAST exam more specific. In a retrospective analysis of 133 cases of blunt abdominal trauma in pediatric patients, Bashar et al. Found that they could improve their specificity from 4% in their cohort to 69% through the addition of clinical findings and lab markers such as elevated transaminases, lipase, and correlation with history and exam features. In a larger prospective study by Fox et al. Of 357 patients, they reported a specificity of 96% when they only counted their FASTs as positive if there was moderate or greater free fluid. Now that you've identified some approaches that improve the performance of the FAST exam in children, let's explore some of the unexpected findings seen sometimes in each part of the exam. What about the perisplenic and perihepatic views? In a review and case series by Ellington et al., you learn that fat can look like free fluid in the perinephric space. Also, children's smaller overall size reduces the average depth of image structures, so more detail is visible. This is why the diaphragm may be visible as a thin black stripe over the liver. What about the pelvic views? In a case series by Barona et al., you learn that free peritoneal fluid may be physiologic in up to 12% of pediatric patients. It's usually seen in the pelvis. If there is no abdominal pain and the patient is alert, it is unlikely to be pathologic. In a study by Rathaus et al., looking at 183 patients with blunt abdominal trauma, those with minimal pelvic fluid or no findings had similarly low rates of organ injury. However, if fluid is seen outside of and within the pelvis, the likelihood of injury is much higher. They also noted that expanding solid organ hematomas may be initially isoechoic, but continued bleeding can make organ injury more visible by ultrasound over time. What about the cardiac views? In a paper by Reddy et al., you find that many children with otherwise normal hearts have trace pericardial fluid. However, only about 1% have more than trace fluid at baseline. Children with more common cardiac lesions like an ASD or VSD have pericardial fluid more frequently. In a study by Blavis et al. Looking at physicians interpreting ultrasound images in trauma patients, you learn that many find it difficult to distinguish between pericardial fat and fluid on ultrasound. And while this study looked at patients with penetrating trauma, it is clear that pericardial fluid can look much like pericardial fat. They found that adding different views to confirm the findings, particularly the parasternal long and IVC views, was a helpful approach. Another technique for distinguishing between pericardial fat and fluid is highlighted in a case report by Mohammed et al. High-resolution imaging such as that seen on transesophageal echo makes pericardial fat look like fluid. Turning up the gain helps. This is an adult case report, but it highlights a confounder that emerges when the heart is viewed under high resolution. Now that we know how others have modified the FAST exam to make it work better for pediatric patients, let's recap what we've learned. The FAST exam is less sensitive in pediatric patients. Combining it with reassuring lab work and serial physical examinations improves the test's sensitivity. Many healthy children have trace pericardial fluid. Obtain multiple views and turn up the gain to ensure that what you are seeing is pericardial fluid and not a fat pad or pleural effusion. Many healthy children have trace pelvic fluid. Repeat your scan, correlate it with the remainder of the exam and lab findings. Evaluate for fluid elsewhere. If your patient has isolated trace pelvic fluid and their physical exam is otherwise reassuring, the finding is most likely incidental. Multiple sonographic views of the same space can help clarify questionable findings and usually requires only minimal time. For example, if you suspect pericardial fluid in subxiphoid views, correlate that with a parasternal long view. Trace pelvic fluid is not as likely pathologic if the right upper quadrant is normal. Shallower depth to target and higher resolution probes can produce findings in children not seen in adults. Consider using ultrasound in known normal children and children with completed radiology ultrasounds to become familiar with the appearance of pathology and normal variants. Understanding normal findings is key to applying the FAST exam in children with high specificity. Though fat is usually seen as relatively bright or hyperechoic, there are some locations in which it can be dark, thus confusing the operator and suggesting fluid. Known locations of occasionally hypoechoic fat include the perinephric and pericardial spaces. Turning up the gain makes the fat marble, unlike fluid. Blood may not be visible initially, so repeat ultrasound after a period of observation is a valuable addition to your first assessment. If you wish to read further on this topic, a list of references is provided here.